Hello, this is Dr. DeChavo, and we are back with the third part of Chapter 2, Immunity. This is very complex stuff, so once again, if you have a question, shoot me an email. Let's look at transplants and how the body responds to transplants, which is amazing to me that we are able to do this and take tissue from one person or a cadaver. Well, cadaver is a person too, or from yourself, or from a pig, or we're trying to create our own substances that we can use in place of transplants and stick them into somebody's body and have it survive in there. And the reason I find this fascinating is because you're basically taking a foreign tissue, which acts as an antigen, which we know at this point is something that our body sees as foreign. And the trick with transplants is to try to make it as non-foreign as possible. And so the tricks to that are to have the best matching donor source as possible, whether it be living or cadaver. And there's a way that we actually test the tissues, which I'll talk about in a little bit. But let's talk about the different tissue sources to begin with. There are 4 major categories. Allogenic, and this is going to be the one that we see, I think, most frequently, is you have a donor and recipient, and we test the tissues to see how similar or close they are. The closer they are, obviously, the better that the recipient will respond to that donor's tissue. Syngenic is going to be donor and recipient are identical twins. Obviously, that would be fantastic. If you are an identical twin, you have the same genetics, you're going to have the same compatibility factors, which we'll talk about in a little bit. But that doesn't happen often. Now, autologous is going to be when the donor and recipient are the same person. So pretty much we'll see this when you store your own blood and you use it in the future. Xenogenic is the use of tissue from another species. For example, a pig heart valve. They used to use those. I don't know if they still do or not when it comes to the actual treatments. I'm not on top of it as much as I am with the research as the pathology, but I also know that they're starting to build scaffolds onto which we can grow our own tissues, which is pretty amazing. And those scaffolds have very little, if any, effect on our immune system. I'm going to try to find a video about that. Moving on. Patterns of transplant reactions. So hyperacute, if you look at these, there's 3, hyperacute, acute, and chronic. So it's going to be a time frame and how they respond with the immune system to this. So hyperacute obviously would be the quickest. It would be immediate to 3 days after the transplant. And the complement system kicks in, send signals to those B cells. The B cells would create the antibodies, and the antibodies will form antibody-antigen complexes or try to destroy the antigens, which in this case is the tissue. Now, the problem with that is the tissue hasn't had a chance to get neovascularization, very big word for new vascularity or a new blood supply. And because it doesn't have a new blood supply, it can actually necrose and die, and that tissue won't be viable anymore. An acute tissue rejection is going to be the most common and treatable. It occurs between, once again, here's our time frame, 4 days and 3 months. And this will be a cell-mediated response. So we'll have those T cells come in directly and cause a response. Probably have other white blood cells like neutrophils come in and try to attack the tissue. And what happens with this is the tissue may get a new blood supply and become a viable living tissue in the recipient, but that recipient then will present with systemic effects of an infection. Fever, redness, swelling at the site, tenderness at the site, and impaired function of that organ itself, whatever that organ may be. A chronic tissue rejection would be 4 months and above. So once again, there's your specific time frame. This is most likely an antibody-mediated response once again. And those antibodies and the complement cells will deposit in the vessels of the transplanted tissue. That will cause a decrease in the blood supply to that tissue. It's almost the same process as hardening of blood vessels. So if you imagine the blood vessels cut and we're looking into the opening of the blood vessel itself, the antibodies in the complement system will build up on the walls of the blood vessel. And if they continue to build up and build up and build up, eventually we can completely cut off the blood supply because we're simply blocking that blood vessel. And once again, we're looking into that blood vessel on end as if it's a tube, and we're looking at the opening of the tube. It's the same process that actually happens with atherosclerosis, where we get inflammation and then depositing of hardened tissues on the inside of blood vessels. And I've seen blood vessels so hard with that, they're actually hard. They sound hard. You can actually click them. They're so thick and hardened. But anyway, the antibodies in the complement system will send antibody complex and white blood cells to that area, and it can block off the blood vessels. And that'll lead to ischemia. I don't know if you remember that word ischemia, but it is lack of blood supply. Obviously, any viable tissue in the body needs a blood supply, unless it's something like cartilage, unless it's something like cartilage doesn't need a direct blood supply. All other tissues will need a blood supply if they're a living tissue. So that could damage, obviously, that transplanted tissue that we have in that patient. Now, with transplants, the patients will have to undergo, they call it HLA testing or human leukocyte antigen testing. This deals with something called the major histocompatibility complex. This sounds really huge and complex. I'm going to try to make it simple and straightforward for you. We have genes that code for proteins. They're actually glycoproteins because they're part protein, part sugar on cell surfaces. So if these are the cells of our bodies, on the surface of that cell, we basically have touching the surface of the cell and covering the surface of the cell glycoproteins. And those glycoproteins allow our body to recognize those cells as our own cells once again. And this is what contributes to our major histocompatibility complex. There are many variations of these proteins that you can find on cell surfaces. So it's very difficult to find two people with the same or similar HLA tissue typing. And this is the tissue typing that they'll do before somebody can donate, say, kidney to a recipient. Now, receptors are on all of our cell surfaces, but we also have major histocompatibility complexes on macrophages. And if we send a signal to those receptors on macrophages saying that there's foreign particles in the body, they'll get turned on. Well, if we put a tissue into our body that's not well matched, we'll stimulate this signaling complex and release signals from our cells that'll go to macrophages and that'll trigger them to turn on and ingest those foreign particles. Does that make sense? That's a little bit of a difficult concept. Now, in order to match, you would take a test and see how many surface receptors or signalers match those of the person that you're going to donate to. And you want to get as many as you can match as possible. I have a little video about that in the supplemental information. So I would suggest going on over, watching that, and it'll help to solidify some of these complexes. But if it doesn't make sense, by all means, shoot me an email. So different types of transplant classifications / rejections. So you can have either the host fighting the graft, which is pretty obvious. You're going to get a tissue implanted into your body. Your body is going to see that as being a foreign invader, also known as an antigen. It's going to somewhat fight that. And that's why people with transplants will need to be on immune suppressors to keep their immune response lower so they don't kill off that transplant tissue. You can also have graft versus host. So you'll see this with bone marrow transplants because this is where we create white blood cells and red blood cells and platelets. So if you get a bone marrow transplant in someone who has a decreased immune response, that transplant can actually launch a cell-mediated immune response towards the host. That host already has a decreased immune system because they're unable to create the white blood cells that they need in their own bone marrow, and that transplanted bone marrow will actually attack the host itself. So once again, the treatment's immunosuppressive therapy to keep that host, that donated tissue immune response down. So tricky stuff, very, very tricky stuff for sure. Question time. The best type of transplant to prevent rejection would be A, allogenic, B, xenogenic, C, autologous, or D, synergenic, or syngenic, I'm sorry. All right. Autoimmune disorders, why? And I put why, because we don't know why. We wish we knew why, because this is when people's bodies attack themselves. Their immune system becomes hyperactive and starts to attack different tissues throughout the body, depending on the different disorders. There are several of them. We're only going to go over one or two. I also think there's a ton of these that we don't quite understand yet. But so with autoimmune disorders, auto means self, immune. Autoimmune disorders will be when our immune system attacks itself. And basically what happens is our body loses the ability to recognize its tissues as its own. And the defenses attack that person's own tissues. It can affect any tissue. Different diseases tend to affect specific tissues. For example, rheumatoid likes to affect the joints. Systemic lupus, we're going to go through, attacks multiple tissues. So different diseases will affect different tissues. The mechanism as to why this happens is not clear. This is the million-dollar question. If we only knew, we could treat, but we don't know. There seems to be a link with stress, and I think that's why your book goes over stress at the beginning. Stress will either trigger the onset or the exacerbations of these diseases. Genetics can play a role as well. Most prevalent in females. I wonder if there's a correlation between females and stress there. Interesting thought. So abnormal stressor usually triggers the onset of it and also the exacerbations. So it'll remit and relapse. You'll have exacerbations and then you'll undergo remissions. It could be with stress. Sometimes it's not. Some of the examples, or one of the examples that I give is systemic, and your book gives, is systemic lupus. And I do have a picture that I will share with you with the malar rash. And the malar rash is the rash that goes across the nose and the cheeks with SLE. And they thought, now I'm hearing different things. This is interesting because I looked it up online because, sometimes things change, and it's been 20 years since I got my doctorate. But lupus means wolf. And what I had read and heard is that they felt that the rash, or the malar rash that goes across your nose and your cheeks, and if you're not familiar with a malar or a butterfly rash, you can pause the tape and go to your supplemental information, and I'll have a picture of that malar rash for you. And what I had heard is that they felt it looked like the pattern of the hair color on the wolf across the cheeks. But then I also read that they felt that it resembled wolf bites across the face. But once you see that malar rash, also known as a butterfly rash because it spreads out like it has wings and then it thins out across the nose, you'll never forget it. So this is a chronic inflammatory autoimmune condition. Now, this is systemic as opposed to discoid, which only affects the skin. So there are two different types. But people, I think, will also use discoid to describe the skin rashes in systemic lupus. This remits and exacerbates according to stressors. This can be mild to severe, more common in women, Asians, and African Americans. Once again, the cause is unclear. This is going to be a broken record for this. It's thought that those B cells are going to activate the autoantibodies, which will attack your cells, and they'll form with autoantigens complexes that will attack and deposit into the patient's tissues. You can also have hyperactive T cells, which once again will trigger the B cells to form more antibodies and antigens. And it's a triple threat because it has repressed T suppressor cells, which can't tell that body to turn off the immune system. So triple threat there. Excuse me. So diagnostic criteria. So I will in some cases give you diagnostic criteria because some of it I'll need to explain. Any of the diagnoses or treatments, because I told you I was going to limit it, any of the diagnosis and treatments that I talk about in my lecture notes are going to be fair game for questions. Any of the ones that are in the book above and beyond my notes will not. So once again, all the questions will come from my notes. I put this in here. There's a nice mnemonic, Soap Brian MD, that gives you diagnostic criteria mnemonic for SLE, and you need to have 4 or more of the following to have a diagnosis of this. So serositis. This is when the serous membranes of the internal organs can get infected and, inflamed. Itis, once again, as an ending or a suffix, denotes inflammation. So that means the lining around the heart, the lungs, and the abdominal organs. So I wanted to explain that. So serous membranes are on the enclosed abdominal and thoracic cavities. Mucous membranes are open to the environment, such as the lining of the mouth all the way down through the tube of the GI tract. Oral ulcers. Arthritis. They can get polyarthritis. There's actually a polyarthritis disease into itself, which is separate from this. But polyarthritis means that they have multiple joints that are swollen. Sensitivity to light, blood disorders, decreased counts. Renal involvement. Those autoantigen complexes can actually deposit into the kidneys, which can decrease kidney function. Immunological phenomena, decreased white blood cells is what they mean by that. Positive anti-nuclear antibody is a blood test that shows whether we have antibodies attacking some of the nuclear components in cells themselves. And this can be intermittently positive. So you may test it at one point and it'll be positive, and another it may not. So once again, you got to have 4 more of these criteria. And it's an ANA, that may sound more familiar, can be positive in other diseases as well. Neurological disorders such as seizures, any dementia, that malar rash or the butterfly rash, which is over the cheeks, and then a discoid rash, which is a patchy redness that can cause scarring on the face. I don't know if you remember the singer Seal. I can probably pop a picture in there, who has a discoid rash. So it can be patchy redness that eventually can turn into bumpy scarring on the skin. And I'll put a picture in there for you of that as well in your supplemental material. So there are 11 criteria, 4 of which have to be positive for a positive diagnosis of this. X-rays would show excuse me, damage to joints, elevated sedimentation rate, is a blood test, C-reactive protein for your inflammation, your analysis to see if you're depositing any of those complexes or any breakdown in the glomerular unit. We'll get into that in the future. But if you start to damage the filtration system of the kidney, you're going to start dumping proteins and glucose into the urine. So that'll start to show up. Echocardiogram to see if there's any pericarditis or inflammation around the heart. Blood tests for any other complications that could be possible. Excuse me. So no cure, stress management and health promotion is good for everyone, right? But really good for people with SLE. Anti-inflammatories, anti-malarials help their, help some of their symptomatology. Corticosteroids help everything. You know, if we don't know what to do, we give steroids. That helps to decrease inflammation in our response to things and also helps with the immune system overreacting. Okay, plasmapheresis, this was interesting. They actually would do this to get rid of some of those antigen-antibody complexes so we don't deposit them as much into the tissues, and hopefully they'll help a little bit with some of the disease progression. Here's a chart of some of those side effects or manifestations of SLE. What I will test you on, once again, is in the notes. But if this helps you to look at some of this out of the context of the notes, I would always kind of study off of things like this. It's just another way to help you study. Another question, and then we're going to take a little break. In SLE, some positive signs include all of the following, excluding malar rash, decreased white blood cells, proper platelet count with testing, and joint inflammation. All right, answer that question, and I will see you in the next video.